Thanks very much for joining us on the Diagnosing Healthcare podcast from Epstein Becker Green. I'm pleased today to be the host for this podcast today, and I'm joined by my esteemed colleague Karen Mandelbaum, who will I'll let her introduce herself because her background is so extraordinary. So today we're going to be talking about the down low on data for value-based entities and their participating providers. And I'm a partner in the Washington D.C. office of the firm, and I help lead our value-based care practice, and Karen is a part of our practice as well. And we represent payors, providers, value-based MSOs, value-based enablement companies, technology vendors, on everything related to value-based care, from traditional managed care, shared savings and capitation payments, to a lot of work in CMS-sponsored models under MSSP or ACO REACH. And one of the reason that we're going to be talking to Karen specifically today is that an emerging trend that we've seen in the last 5-10 years related to value-based care is the primacy of data in making the enterprise successful. And a lot of times in our negotiation of those risk arrangements or those shared savings arrangements, data is something that is discussed. Often it is discussed aspirationally, but Karen has really been crucial in helping our clients sort out how to make it a reality, and particularly addressing some of the complexities of value-based enablement entities working with both health plans and providers in a traditional Medicare Advantage or Medicaid managed care or commercial managed care environment, but also deploying similar infrastructure in MSSP ACOs or ACO REACH. And so, Karen, if you wouldn't mind starting by just sort of introducing your background and then explaining a little bit of the sort of landscape of laws that apply and the different regulations of data regulations, information blocking regulations, privacy and security at the federal and state level, some of the issues that you run into related to substance use disorder treatment records specifically. Not a short list to talk about, but if you don't mind just sort of framing up a little bit about the unique and extraordinary background that you bring to this conversation.
So, Kevin, I joined Epstein Becker I came from CMS, from the Centers for Medicare and Medicaid Services, where I had spent the better part of 7+ years serving as the director of security and privacy policy for the agency. I started off working on the health insurance marketplace program under the ACA, standing up that privacy program, and then I was the special assistant to the chief information officer, and then I had this enterprise-wide sort of look-see into the privacy and security programs that each part of the agency was standing up. And at the time, the Center for Medicare and Medicaid Innovation, CMMI, was rolling out their ACO programs. They were, busy trying to figure out how to, sort of set them up and how to arrange them. There was, MSSP had already published regulations. CMMI was working on the models. They had the Pioneer model. They had the Accountable Healthcare Communities models that were moving forward. And they were all concerned about privacy and the security of the data, primarily because CMS was providing these sort of downloads of beneficiary data from the agency directly, really from the MACs to the ACO enabler organizations. I don't even think they were called enablers at that time. They didn't know exactly what the guidance was supposed to be when they were taking these what was considered federal data, right, and putting it into the private sector. To frame this up, the federal privacy law that governs CMS data is the Privacy Act. HIPAA does play, and HIPAA is another federal law that CMS as an agency has to contend with. But as a general rule, the first and primary law that regulates the data that CMS collects is the Privacy Act. And the Privacy Act is the kind of privacy law that is a restrictive type of law where Congress gives a federal agency the authority to collect certain data for certain purposes, and they're not supposed to use it for other things. So the way that it works is the Privacy Act requires federal agencies that collect personally identifiable information about individuals, like CMS collects claims data, for instance, which was the basis for what for the data that's being shared with the ACO organizations. They collect that data and it's supposed to be used to pay claims. It can be used for a variety of other purposes, but those purposes are supposed to be articulated in what are called routine uses. The agency is supposed to publish a systems of record notice that tells the public how the information is going to be used. And those routine uses are specified in the Federal Register. So when CMS discloses the claims data, the beneficiary data, the Privacy Act enters into the agreements in addition to HIPAA. But at the same time, private organizations are not obligated to comply with the Privacy Act. That's a federal agency rule for how they treat the information. So oftentimes the recipient, the ACO organization, can get confused as to how they're supposed to treat that information. And unfortunately, I think as you're familiar with on your side of your work with the ACOs, those agreements are never really very clear. The agreements give you just enough information to be confusing, and which makes it really complicated for our clients sometimes to understand the multitude of different ways that they may want to use information, but then they feel as though they're constrained in certain ways from using the information that they get from CMS. So there's the Privacy Act, there's HIPAA. Then at the state level, many, if not most states have enacted their own privacy and security laws. Like, for instance, like the state of New York has the New York Shield Act that has more stringent requirements for, like, for instance, reporting breaches than HIPAA breaches. So our clients that may be located in New York or that are operating in New York may have to consider both federal and state incident response or breach notification issues, like if there is like a ransomware attack or something like that that they have to contend with.
So, Karen, that's an extremely helpful background on some of the unique issues that come with getting access to CMS data that many people sort of getting into these demonstration models may not have ever had experience with before. Can you talk a little bit about if, let's say, a value-based enablement company or a risk-bearing provider is working with an ACO reach entity that has a data use agreement with CMS. There's both HIPAA issues coming from the providers up, and then there's data use obligations coming from CMS through the ACO down. How do you sort of work with sort of these enablement entities to reconcile those obligations?
So everybody likes business associate agreements, but you're not going to get CMS to enter into a business associate agreement. Um, the data use agreement is the agreement of choice. It should not be confused with a HIPAA data use agreement. Okay, under HIPAA when data is disclosed, like in a limited data set for research purposes, then a data that there is a term of art under HIPAA called data use agreement, but that's not the data use agreement that CMS asks ACO enablers to enter into. The data use agreement that CMS asks ACO enablers to enter into is that Privacy Act document, and it's primarily used for tracking data. It has some enforcement language in it. It basically says that if you use the information or you disclose it for the wrong purposes or in violation of the underlying agreements, then there are civil and criminal penalties sometimes associated with it. So it's a little bit scary. But the bottom line is that it's the mechanism that CMS uses to track disclosures. And the way that we try to advise our clients is that they should be tracking disclosures in a similar manner. That if they are disclosing CMS data downstream to, say, a vendor that's helping them understand or curate that data in some way, shape, or form, then they need to document that disclosure in a same or similar way as the data use agreement does. Obviously, if the vendor misuses the information, then there should be some consequence, whether it's like a legal consequence that the agreement can be terminated immediately, or it will be reported to law enforcement or something like that if like some identity theft or something might be associated or with it. But the same kind of tracking mechanism that the data use agreement serves at the CMS level is the way that the ACO enabler should be thinking about how CMS data that's being shared downstream should be used. With respect to the participating provider organizations, again, you know, HIPAA is a has very useful tools to use when sort of attaching the rights and the responsibilities when information is being shared. But oftentimes it gets to be like a little over business associate in nature. And so you need to take a step back and really understand whether information is being shared with a third party, or if it's being disclosed to a third party, or if it's really just a disclosure within the healthcare environment. And then there may be other ways under HIPAA to make that disclosure. There might be some exceptions that business associate from the need to have a business associate agreement, especially when you're using the information for treatment, which is really the focus that we like to guide our clients to be thinking in. And recently, just in the last couple of months, the Office for Civil Rights published new guidance specifically about sharing information within an ACO for treatment purposes without business associate agreements. And so it's really important for us to keep in line with what OCR is saying about the flexibilities that HIPAA has. HIPAA didn't need to be modified. It just needed, clearer guidance so that ACO enablers could understand how, as the payment landscape is changing, the treatment landscape is changing. And that's where HIPAA needs, and the flexibilities that are there in HIPAA are available and can be leveraged. And it was really important that OCR made that clarification in their guidance.
And thanks so much, Karen. That's great to hear. I know we've run into lots of complications with some of our ACOs and ACO enablement clients on those issues. Um, Before we talk a little bit about part two, can you talk a little bit about some of the issues that you see value-based enablement companies and risk-bearing MSOs, IPAs have in Medicare Advantage or in managed care delivery systems? Because that's a different ecosystem, right? We're not dealing with data use agreements. The only data is coming from obviously the providers up and from the plan down, but you still have a lot of practical and legal issues that get raised often under HIPAA or under contracts.
Yeah. You know, when I was at CMS, one of the projects that I sort of stepped into was a project that came down to CMS from the Department of Health and Human Services. So, as an operating division of the Department of Health and Human Services, CMS was considered a hybrid organization under HIPAA that was part of HHS's hybrid organization. I know that's a little complicated, but a hybrid organization under HIPAA is one that does both covered activities that if those activities would be standalone activities, they would be a covered entity. And there are also whole parts of its operation that are not covered under HIPAA at all. So parts of CMS are covered, are covered components of CMS, and parts of them are not. So the marketplace program, SOCIO, is not considered a covered component. It's not, it doesn't have covered entity functions, and it's not governed under HIPAA. On the Medicare side, there are two parts to the Center for Medicare within CMS. One part is the managed care part, the MA part. The other part is Medicare fee for service. Medicare fee for service is a covered component. If it were to be just a standalone component, a standalone organization, it would be a covered entity. It would look just like an insurance company. And so HIPAA applies to it, to the fee for service part. The Medicare Advantage part, HIPAA does not apply to that part of the agency, because all CMS is doing is writing rules about how insurance companies should meet the Medicare requirements, which is not, that's not an insurance function. And so it's not a covered entity.
CMS isn't.
CMS is not. In that role, CMS is not a covered entity. And so in that role, it in that, on Medicare Advantage side of things, only the plans are covered entities. They are their own covered entities that are governed under HIPAA, and they're responsible to have their own HIPAA policies and procedures, and they make their own rules, and it's on their it's on their sort of watch, I guess I would say. Yes, they do get Medicare beneficiary information, but they do not get it from CMS. It's not governed under the Privacy Act. It doesn't, it has no influence from CMS's HIPAA privacy rules that they've established themselves. It's only from the beneficiary alone, right? So if I decide that I'm going to enroll in a Medicare Advantage plan, I choose the plan. I look at its policies and procedures, HIPAA policies and procedures, and I recognize that I'm agreeing to sign up with that insurance company. And so that it all begins and it all focuses around that plan and around that insurance company. And it doesn't have the same influence from the Federal Privacy Act or from any of those types of organizations. Now that doesn't mean that there aren't some aspects of privacy protection that the Medicare Advantage and Medicare Part D rules don't sort of influence. Like, for instance, like with respect to the agents and brokers and the purchasing, and the sort of, I guess I would say, the purposes behind the privacy, privacy protections, things like having adequate notice and an opportunity to opt out and things like that. Those definitely are part of the MA and the Part D rules, but they're really customized to the services that are sort of bringing those Medicare Advantage beneficiaries into the world of Medicare Advantage, as opposed to how their claims data and how their medical information is handled and treated.
It's a really helpful clarification, Karen. We're coming up on sort of the end of our time together, but I know we talk a lot about the rules that govern data exchange, but I think what a lot of our value-based enablement clients grapple with is making sure that the data that they're getting from ACOs and from payers and from providers is um, is usable, is sort of in a format, and is in a structure that actually supports their operations in doing analytics and doing risk stratification and doing care management. Can you talk a little bit about some of the considerations, some of the experience that you think about, like what are some things that you've seen providers struggle with? What are some of the good solutions that you've seen about making sure the data is actually good?
So that's a really big question. Here in the United States, the way that healthcare has become digitized over the last, say, 30 years, we've used the term data gets siloed. So every single healthcare organization, whether it's a provider organization or whether it's a payer organization, kind of has their own way of keeping track of records and managing their information systems. And when everything was paper based, it was sort of complicated. But now that everything has changed over to being electronic, maybe upwards of 80% of hospitals and health systems and insurance companies are fully electronic, or use electronic data systems and health and record keeping systems. Um, the hope would have been that that there would be some sort of standardization and some sort of method for those systems to be able to communicate with each other. But unfortunately, this first phase, though it was very successful of of changing over or transforming the healthcare industry from paper to electronic, it also created electronic silos. So it's really almost just as hard to sort of crack the nut and to have data understood between and across systems. HIPAA gave us a handful of transactions, eligibility and enrollment, claims, authorizations. There's 7 different transactions that HIPAA governs, and they're electronic standard transactions. And no matter how data is kept or organized, or what data warehouses look like, or how they're configured within a payer or within a provider, um, the transaction itself that is sent back and forth, so when a patient shows up at a doctor's office and the doctor's office needs to verify the benefits that that patient has, that transaction has been digitized and it's standardized. But for the vast majority of the transactions that we need to be able to communicate, and the data, that data that actually will help us um, reduce costs, know our it'll allow doctors to understand and know their patients better. It'll allow insurance companies to understand what the risks are and how to how to better manage the resources that they have. That data is really locked in these systems. It's not to say that that's something that's insurmountable. It's just something that we have to kind of have a little bit of patience with and understanding with, and recognize that there are new technologies on the horizon that are that will make things not I'm not going to say easy, because it's not easy, but the idea is that we have to be willing to to be open minded, to think about ways that data can be better used. It can be gathered in a more uniform way to make it more meaningful. The problems that we have with our systems understanding each other are going to be around for a while. One part that we should talk about just briefly is the efforts of the Office of the National Coordinator for Health IT. It the Assistant Secretary for Technology and Policy heads up the Office for the National Coordinator these days, um, and they're working very hard to um, to 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 sort of push through an initiative called the Trusted Exchange Framework and Common Agreement. It's a useful way for our ACO enabler clients to be able to meet some of their quality measures when they have to report MIPS and when they have to participate in certain CMS programs like promoting interoperability. By signing up and agreeing to participate in the Trusted Exchange Framework and Common Agreement, they can get all of the points that they need for their MIPS participation in one fell swoop. It's kind of an easy way to have access to admit, discharge, and transfer information. And so every single healthcare provider that uses those systems have the option of flipping the TEFCA switch, so to speak, within their systems. And so it'll help us get to a place where our data will become more standard, and then it will be more meaningful.
Thank you so much for all this great insight. I know from working with you directly on many matters involving value-based care that you're able to really, working with some of these provider entities, unlock data and solutions that um, they may not have understood were even possible. And I think, in my risk arrangements in managed care, um, it's clear that data access is often where value-based arrangements run aground, and that really great economic modeling, really great clinical modeling, and even good sort of business solutions can't solve a value-based care delivery system that has bad data. And I've seen relationships that started off really strong, really souring over data exchange, and it's clear that having these conversations early, if not even before executing risk arrangements or value-based enablement arrangements, can make a really big difference in leading to a successful collaboration down the road. And so, Karen, I just really, really appreciate you sharing your insights with
Yeah.
our listeners today, and want to thank the audience for plugging into another episode of Diagnosing Healthcare podcast. If you have any questions for me or for Karen, please feel free to reach out. But uh, thanks again, Karen. It's always a pleasure.
This podcast is presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.